Welcome to this clinical pharmacology case study focusing on chronic kidney disease, also known as renal failure. Today, we'll review a patient case, analyze their medications, and discuss the appropriate pharmacological interventions. Let's look a minute. Okay, this is the case of Mrs. K, a 67-year-old female weighing 62 kilograms. She has a long-standing history of type 2 diabetes and hypertension, both of which are major risk factors for chronic kidney disease. She now presents with swelling in her legs, fatigue, and reduced urine output, all classic symptoms suggesting a decline in kidney function. Let's look a minute. On examination, her blood pressure is elevated at 164/94, and her heart rate is 78 beats per minute. Lab tests reveal a serum creatinine of 3.2 milligrams per deciliter and an estimated glomerular filtration rate of just 22, placing her in stage 4 chronic kidney disease. Her potassium is also high at 5.6. She's currently on metformin, enalapril, and paracetamol. Okay, pause the video and try to find the key clinical issues. Okay, let's see. First, her CKD is advanced, and she's showing signs of hyperkalemia. Second, metformin use is inappropriate at her current kidney function due to the risk of lactic acidosis. Third, ACE inhibitors like enalapril can further increase potassium levels. Lastly, there's a risk of renal complications like anemia and bone disease that also need to be addressed. Okay, as a pharmacist, what's your suggestions? Pause the video and think. The first step is to stop metformin because of the risk of lactic acidosis. Linagliptin is a better choice as it doesn't require renal dose adjustment. Enalapril should also be discontinued to avoid worsening hyperkalemia. Amlodipine can be used instead to control her blood pressure. A loop diuretic like furosemide will help reduce fluid retention and lower potassium. Lastly, she should be monitored for anemia and bone disorders commonly associated with CKD. Patient education plays a vital role. Let's see. Mrs. K should avoid over-the-counter NSAIDs, which can worsen kidney function. A low-potassium diet must be followed. She should be informed about the need for regular lab tests and the importance of controlling blood sugar and blood pressure. It's also time to start discussions about dialysis options. The follow-up plan includes weekly monitoring of her potassium levels and monthly renal panels. Given the progression of her CKD, she should be referred to a nephrologist to explore the options for dialysis and long-term renal care. Okay, let's see one more case. Our patient is Mr. S, a 75-year-old male with a history of type 2 diabetes, hypertension, and osteoarthritis. He was admitted to the hospital with complaints of fever, decreased urine output, and confusion. He weighs 68 kilograms and has no prior history of kidney disease. Pause the video, read and understand. Okay. On admission, Mr. Siva was hypotensive with a blood pressure of 90/60, and his heart rate was 98 beats per minute. Lab reports show a rising serum creatinine from a baseline of 1.1 to 2.9 milligrams per deciliter over 2 days. His blood urea nitrogen is 46 milligrams per deciliter, and urine output has dropped to less than 400 milliliters in 24 hours. He is currently on metformin, losartan, and ibuprofen. Pause the video and find the clinical issues. Mr. S is experiencing acute kidney injury, likely due to a combination of dehydration, sepsis, and nephrotoxic drug exposure. NSAIDs like ibuprofen and ARBs like losartan can both impair renal perfusion, especially in elderly patients. Also, metformin is contraindicated in AKI due to the risk of lactic acidosis. Okay, can you suggest any intervention for these cases? Let's see. The immediate step is to discontinue nephrotoxic medications, ibuprofen and losartan. Metformin must also be stopped. IV fluids are initiated to restore perfusion, and broad-spectrum antibiotics are started for suspected sepsis. Close monitoring of electrolytes and renal function is essential. Once stable, alternative antihypertensive like amlodipine may be considered. It's important to educate Mr. S and his caregivers about the risks of NSAIDs and the importance of staying hydrated, especially during infections or hot weather. They should be advised to report signs of reduced urine output or fatigue early. A list of medications to avoid in the future should be provided. Let's see the follow-up plan. The patient will require daily renal function tests until recovery. Blood pressure should be closely monitored, and diabetes management should be reevaluated. A nephrology referral is essential if renal function does not normalize. Long-term planning should include medication reconciliation and regular renal function checks. That's all for today. Thank you for watching. Like, share, and subscribe our channel for more exclusives.